All right. It is 1 minute to 6:30 Eastern Daylight Time. Looking forward to anyone who's watching to answer your pharmacy COVID questions. I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice at the University of Rhode Island. Like many of you, or maybe not some of you, I'm in my house. I'm very lucky to not be on the front lines like you all are, and really appreciate all the work that everyone is doing out there on the front lines. And there are lots of questions, so that is important. Oh, maybe now I'm live public. Okay. So we're trying something new here. We're doing Facebook Live. Thanks to Matt LaCroix and Chris Federico and Emily Ubing for a student graduate in a month or so. A little more than a month for helping out with answering your questions. Thanks for everyone who submitted questions. I have some of those answers pulled up. If you want to go to pollev.com/URI 2020, you can enter your questions. We'll try to get some of these answered. You can also, if you're watching on Facebook, you can also enter some of these things. Okay. So one of the questions, we'll just start with the things that people were most interested in was, is it known whether or not the virus can be transmitted through blood? There's conflicting reports and curious the implications on blood donations across the state, which are usually in short supply. So, okay. Okay. All right, we're just going to check and see if I'm actually live here. We'll see what's going on. Looks like things are going well here. Okay. Okay. Now I'm confirmed that I'm live. Okay, so we're answering your questions about COVID-19, and I'm Jeff Bratberg. Apologize to repeat, but I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice at the University of Rhode Island, so we're public to the world here. I'm seeing your comments and your questions come in. Thanks again to Christopher Federico and RIPA members Christopher Federico, incoming president Matt LaCroix, current president Kenny Correa, and my student Emerald Rourke, and Chris and Matt's student Emily Ubing for helping out with answering some of these questions, for all your questions on the poll everywhere. So one of the first questions, again, if you were listening now, I'm going to repeat it. And if you just started, you don't know it was repeated. Is it known whether or not the virus can be transmitted through blood? There's conflicting reports. Curious about the implications for blood donations across the state. Are blood banks screening for the virus? So currently there's no evidence to suggest it's transmitted by blood. One of the reasons we have such stringent shelter in place, healthy distancing, physical distancing, is because of its respiratory spread and spread via objects or fomites, things that you touch. And so the emphasis is on disinfection, staying 6 feet away from people, coughing in sneezing in your arm like this, doing things like not working if you're sick. One of the important things for Rhode Island just today is that that testing is available for anyone who is symptomatic, not just high-risk people, which pharmacists are essential, and they are high risk. So we were in that group before, or people who work in essential industries, people who work in hospitals, long-term care facilities, things like that could get tested. Now we've expanded testing greatly in the state, and so that's fabulous to kind of get a better handle on who has the disease. But in terms of blood transfusions, I'm a blood donor, and I encourage people to be doing that. It's not transmitted by blood. Other respiratory diseases are not known to be transmitted through blood as well. So the screening process currently in place for blood donors requires you to be in good health. The CDC, Centers for Disease Control and Prevention, today came out with some publications on pre-symptomatic spread. There's an article in some of the major newspapers, national newspapers and others, that you may be able to transmit the virus up to 48 hours or 2 days before you are symptomatic if you develop symptoms. So that's why there's such spread in families. That's why there's spread in workplaces, and really emphasizes that we don't touch our face, that we wash our hands, use hand sanitizer, all those things. So the screening process for blood donation, if a person becomes sick, they're supposed to contact the donations. It's not required currently. Our current research that COVID-19 is a test before donation. Obviously, with exceptional and unimaginable numbers of people in critical care, the blood supply, which is already strained, is something that we need to keep up. And so FDA requires blood establishments to refrain from accepting blood from people who have traveled to areas with COVID-19 outbreaks as defined by CDC, lived with individuals diagnosed or suspected of COVID-19 infection, so you'd have to put that on your blood donation form, or been diagnosed with or suspected of having COVID-19 infection. And we have answers to these questions people submitted online, and we have some links to do that. Okay, so again, send us your questions. We'll see what's going on. One other question: if someone calls the pharmacy or shows up with symptoms, what should I do? So I alluded to that we now have in Rhode Island widespread testing for anyone who wants a test. That just hot off the presses Monday night from the Rhode Island Department of Health. So if they show up with symptoms, you should send them away. Try to stay 6 feet away from them. They need to call their doctor. There are 3 testing sites at the public higher education institutions in Rhode Island, at URI in the main campus in Kingston, at Rhode Island College in Providence, and at the Warwick campus of CCRI. So those are where the drive-through testing is happening. You have to go by appointment only. They only test people who are 12 and up. And again, you need your doctor to call in the prescription there. So that's important in terms of testing. So if they call the pharmacy, tell them they need to call their doctor if they have symptoms. Probably one important piece of advice is we're trying to preserve both personal protective equipment or PPE, and still making sure that tests are available for people with severe disease admitted to the hospital or admitted to intensive care units or ICUs. Is if you're healthy enough to stay home, if you don't have trouble breathing, you should stay home, quarantine yourself away from your family, and only when you have symptoms that are severe is to call. This guidance is subject to change on a daily basis, so if you're watching this in a recorded way, just a note that the Rhode Island Department of Health will do that. So that's if you call pharmacy or show up with symptoms. I work in a pharmacy. Should I wear a mask? So one of the most essential parts of PPE, I'm concerned, and I want to protect myself. So as healthcare workers who are essential, who have great contact with the public, or probably more people in the public who may or may not show symptoms, who are more likely to be high risk, there's guidance on national websites, on RIPA's website, to get you links on what to do what we should do in terms of masking. A couple weeks ago, the American Pharmacists Association voted on guidance that pharmacists do need to be protected with PPE. But the problem is that we are very limited in PPE. And so even people who work in home care or long-term care, or what was said on the provider call today, April 1st, is to, even if you have a surgical mask or an N95 mask, that you need to save it if it's not damaged or soiled or wet, and use it for 3 days. And that's what's happening really nationally. So to get masks to pharmacies, some pharmacies are installing plexiglass enclosures, shower curtains are being used. Lots of things are being used to protect yourself, and I can't say not to do that. I think in terms of a mask, though, for pharmacy personnel and pharmacists and technicians and clerks, is that if you wear a mask, you're really protecting yourself from infecting your high-risk patients or your high-risk colleagues. The other thing is, since we're not in a culture to protect like other East Asian countries where during flu season everyone wears a mask and they're plentiful and accessible, is to really think about the impression you give your patients. One of the answers we put that we wrote on the study is that, or on the answering this question, is up to 1 in 4 people. This came out today or yesterday. 1 in 4 people have asymptomatic, are infected but asymptomatic, but could still spread. And also highlighting a story in the New York Times today that in South Korea, pharmacy personnel, community pharmacists were essential in distributing masks. I don't know if that's a future goal for Rhode Island or the U.S. And so you're exposed to lots of people and you want to protect them. Really, you're wearing a mask to protect them. The other thing that you should do is if you're wearing, again, if you're wearing a mask to protect patients, you should tell them that's why you're wearing a mask. But if you're sick, which is when you should wear a mask, a surgical mask, you shouldn't be at work anyway, right? So if you have symptoms, you should not be coming to work. I read today that a CVS pharmacy in Wayland Square was closed because of someone who was positive for COVID-19. I read another story today that if you have symptoms of COVID-19, again, just to be very clear, it's fever, very prevalent, cough, similar to influenza, shortness of breath, which is not influenza, a rarer but more specific to COVID-19 or coronaviruses is loss of taste or loss of smell. There was on one of the calls today, someone presented without fever, but had GI symptoms. So that's one thing that people are seeing. So it doesn't, again, if you're having GI symptoms, if you're having diarrhea, nausea, but you don't have shortness of breath, if you don't require hospital level care, stay at home, take care of yourself. That's really what we really need to do there. What else did I say? In terms of the types of masks, just to be very clear here, surgical masks are what perhaps the general public should wear or pharmacists should wear. N95 masks are in very short supply. Millions are coming into the country. We're receiving masks in the state today and tomorrow, as reported by the Department of Health. But N95 masks really for folks in direct continuous contact with people with COVID-19. So you have to balance those things. So a really great question and a really complicated answer, and I apologize for that. Something that we hear from our patients are, and I'm sure people have read about all these things already, is the idea of should people, yourself and prominently your patients who are taking ARBs or ACEs, antihypertensives, and anti-angiotensin converting enzyme modifying drugs, or NSAIDs, can they change the risk of COVID? The guidance says not to stop and ask your doctor. What do I tell the doctor when they ask me? So when the doctor asks you, so that's great. We are drug information specialists. So the current data is we don't have any data that NSAIDs actually change the course of disease. So if someone is on NSAIDs, they should not stop taking them. If someone is taking ARBs or ACEs, they should not stop taking them if they're healthy, right? They need to reduce myocardial infarctions, heart attacks, and strokes, things like that. There's still essential meds, and all of the major cardiac associations have recommended that to not stop taking it. There's even some evidence that, as Emily graciously put great data that you'll see here, is that ACE2 is a receptor deep in your lungs that that SARS-CoV-2, but we'll just say COVID-19, which is the disease caused by SARS-CoV-2, it binds to ACE2, and these drugs can modify that receptor. But there's also some data that maybe ARBs actually help with the disease. Again, there's no clinical data. This is in vitro data. Don't start taking or start recommending people take ARBs to try to prevent COVID-19. Here's a blanket statement that applies today. I heard today from my ID physician colleagues, there are no drugs that treat COVID-19. Tell your prescribers that. Tell your patients that. From currently marketed drugs, there is no vaccine, things like that. So yeah, the guidance is don't stop taking NSAIDs. I think that we should just be a little more aware of people who are at risk of NSAIDs. So people who have chronic kidney disease should not be taking NSAIDs. and we'll talk about those kinds of things. Wow. So we have a comment, a live comment here. Will the RIDO be issuing extensions on licensing and CPR certifications as many other states have already done? So I've been privileged to have helped and worked with RIPA to work on regulations that are, all I can say is in process, to further recognize the role of community pharmacists and pharmacists in healthcare, and regulations that will help patients more. I know the American Heart Association today, I got an email from my colleague Christine Eisenhower at URI that certifications will be extended, I think 120 days. We'll post that later, but at least those certifications are being extended, and we have looked into making sure that the lack of an active CPR license doesn't mean you can't immunize. So I hope that answers. In terms of licensing, I don't know what's happening with that. Dr. Friend has a question. Will there eventually be a way to test if someone had COVID-19 after infection has resolved? That was a part of a Bill Gates of Microsoft fame had an op-ed in the Washington Post today, and many others, including Scott Gottlieb and others who are former FDA commissioner under President Trump, have begun planning for when this is over. What are we going to do? What are the things we're going to do? I hope we have a little time to talk about that. So will there be a way to test? So, and that is of great interest at the health department. I did hear that from my colleagues leading this response at RIDO, which for full transparency is my practice site, but I'm not involved directly with the efforts, the heroic, transparent efforts that RIDO is doing to rated probably one of the best responses or the best responses of the state. So you're living in a state that is doing the best in preparedness, and I'm just trying to help deliver that. But serological testing will tell us who's gotten the disease. So if we can extend the data from Singapore and other places in the world where 1 in 4 infections are asymptomatic, we can do serologic testing, antibody testing, just as I could check your antibodies to see if you've been exposed to measles or hepatitis B, which we do in healthcare, and people who immunize to see if we need to revaccinate you or figure out a different plan to protect you from hepatitis B. If we could know whether you're protecting against coronavirus, this coronavirus, that means that if you're a teacher, a pharmacist, a physician, a nurse, an essential healthcare worker, that maybe you wouldn't need as much PPE. Again, these are extrapolations, but serological testing will tell us sort of what the baseline of infections are. So will there ever be? It's being used in Germany right now. The tests are being developed. They're getting approved by FDA, and Rhode Island is definitely very interested in looking to do clinical trials. CDC is here. National Guard is here. Army Corps of Engineers. I mean, we have national efforts going underway for those kinds of things. Here's a question I did not prepare for, much like the other two. Do you think there should be adjustments, suspensions, of outpatient oncology treatment plans so that these immunocompromised individuals aren't visiting the hospital frequently? So I would say that is up to the outpatient oncology. My father-in-law has cancer and has appointments scheduled in Boston next week, and as far as he knows, his provider and institution have provided him with a plan to get his tests done. Nobody can come in. They meet them in a parking lot. So I think that these oncology centers are doing their best to do that. And it really depends on how available providers are, I would say. So it's really up to them. Do I think that they should do that? Yes, I think that whether immunocompromised or high risk or have children or don't have children or are a college student, everybody needs to avoid people at all costs. We've gone from 10 people down to 5. Other states have said don't be around more than 2 people for any duration of time. This is really difficult to hear, thinking of our community pharmacy members who are exposed to the public and the pharmacists who are clinical pharmacists and ambulatory care pharmacists, all encountering patients who at this point are presumed to have COVID-19 because we are experiencing and have experienced widespread community infection, and with lots and lots of many more cases. So as you hear every day, one of the questions I'll kind of jump to is, how do I reduce anxiety? Have this be the only hour you hear about COVID-19 today, I guess. Don't obsess on the data, and understand that this month a lot of things are going to happen. Famous people are going to get infected. Famous people are going to be hospitalized. There's someone that is going to be hospitalized, going to be infected. A colleague of mine, her father's in the ICU. I just found that out an hour ago. We're going to do that. We need to get through it. So focus on doing what we know will flatten the curve, which means not peaking in a way that overwhelms our hospital system. Dr. LaCroix, my colleague and incoming president again of RIPA, just sent out a message to our listserv at the University of Rhode Island College of Pharmacy saying, here are ways that you can help. So if you want to volunteer to help, Rhode Island Department of Health has opportunities. Lifespan has opportunities. But really the best way to get connected to both clinical and non-clinical care, you and your friends, whether you're pharmacy or not, or graduated or not, is go to RI Responds, RIRESPONDS.org. And so RI Responds, essentially, that's where they'll get you on a plan to help out in ways, and you'll get all the emails there. And great, showing what great volunteerism we have in the state is they've greatly expanded their membership. If you live other places, New York, Massachusetts, I expect other states have healthcare ready programs. If you're a retired practitioner, you can do that. If you're in another state and you want to work in Rhode Island, you can get an emergency 90-day license to practice. And there's the link. Thank you, Matt. So that's what's going on there. I extended a little much after that question. Community pharmacy vaccines. I know it's crazy for us to administer without PPE, but should patients be getting pneumonia or Zostrix now? Is the benefit worth the risk for the patient? That is a great question. I don't know the answer to that. I think that COVID's going to be with us, essentially, we have to assume forever in some way. It's peaking now. We've seen success in other countries with social distancing. We've seen stories in the last couple of days that show social distancing has begun to bend the curve in New York. They have a long ways to go. It's bent the curve in Washington, long ways to go. Still lots of deaths in Italy, comparator country to us in terms of their healthcare system and when they did social distancing. So as hard as it is to hear that now our parks are closed and barbershops are closed and only essential businesses are open in Rhode Island and in many other states. I'm in Massachusetts. I'm technically not able to even drive to Rhode Island to work, as I'm sure other folks are in other states. It's just really important to just stay away from folks, because even though some colleagues and friends and family have said, well, aren't we all going to get it? The issue is, are you going to get it and still have access to a ventilator? Is someone that that's high risk going to have access to a ventilator and a person to run it and drugs to sedate you while you're on the ventilator? Don't we want to know whether experimental drug treatments are going to work? And we'll know that in a few months or hopefully maybe even weeks, so we're using the drugs appropriately to keep people out of the ICU, keep people out of the hospital, and those kinds of things. So is it crazy for us to administer without PPE? It's people who qualify for a pneumonia vaccine, just like influenza infection predisposes to more negative outcomes when you get a bacterial pneumonia. And so vaccinating people against flu and pneumonia is important. I think if somebody wants a pneumonia vaccine, they're reducing their risk, right, of perhaps poorer outcomes from any respiratory disease. And while you do risk, being in close contact with someone who's probably high risk because they have a chronic medical condition or they're over 65 to get those pneumonia vaccines, I think Zostrix would be something to pause on. But I think pneumonia vaccines or any vaccine again, we're out of flu season in a month. So keep giving flu vaccines. It's also important. I think it is important to get vaccines. Okay. We hear a lot of benefits of increasing testing. Yeah, testing is literally what is going to solve everything. We were a month too late in this country. We can't just focus on that. We have to focus on expanding testing. So as we wrote in the answers, I think a week ago or maybe 6 days ago, there was a 45-minute test as opposed to 4 hours. Then there was a 30-minute test that was approved. These are FDA approved. You can go to the FDA website and CDC. There's a 30-minute test, a 15-minute test, and then I think yesterday there was a 2-minute test and a 5-minute test. I think it's the 5-minute test that's point of care that is coming to Rhode Island and many other places and will be deployed. It isn't like I know something that you don't, but the more we do testing, really proud of our primary care providers, physician providers who have created respiratory clinics. We now drive-through testing. Again, just to repeat, in case you're just joining, they're testing everyone. Sign up for those provider briefings. We put a link in. You can go to the RIPA COVID-19 website and get all the same information about the calls. They're recorded. The notes are emailed out to keep everybody informed. So you can tell physicians, which I'm sure you're getting lots of questions from physicians about what's going on too. Importantly, these calls have 800 or more thousand people on them. And they're usually 12:30 on Wednesdays, unless something big was announced, like Monday was talking about testing. So what are the downstream effects which may be negative? Sure. So what isn't really talked about in the media is that many countries were scanning people with those infrared scanners to see if you have a fever and put you on a plane or not on a plane or a boat or a ferry or into the hospital. They don't really work. They're up to 30 or 40% inaccurate in having a false negative, meaning you've got a fever and you don't know it, or a false positive, meaning you have a fever, and then resources will be used to protect you about that. So overutilization and improper use of resources, anxiety, yes, all those things. Should we still be selective? I think that even though every test has a degree of false negative and false positive, there are dozens of companies working on testing, and we're going to find out very, very rapidly in a couple weeks because of so many cases. Just like I think we're going to know whether some of the drug countermeasures I'll talk about later are effective or not, and for whom it's effective. Right now, we gave this person this drug and they got better. We gave this person this drug, they didn't get ventilated. This person got ventilated. We don't know. That's anecdotal medicine. And as drug information medication specialists, we have to adhere to the evidence and give. Yes, I'm going to address all the treatments. Thank you for that question. So we'll talk about that. So overutilization, I don't know. I think that the countries that have achieved decreases in social distancing, that have achieved what we're going to get to, right? So COVID's with us forever. We have a vaccine in maybe 18 months that's maybe effective. COVID is incredibly transmissible. This is why we're in this, and incredibly has a higher case fatality ratio. Yesterday, the CDC came out with a list of, and these are all freely available, and I think we posted the links 2 or 3 days ago, talking about age as a risk factor, proven that, chronic medical conditions, so people that we all see in the pharmacy, right? People with diabetes, and we're friends with, and we're related to, and we may have ourselves, cardiovascular disease, respiratory conditions, including asthma and COPD, heart failure, kidney disease, which was actually much lower, and diabetes. So diabetes and respiratory, I think, were the top two, but I'd have to re-verify that. So those are the people who really need to get tested, really need to avoid. We all need to really help to not have access to things, doing things in our pharmacies that some grocery stores and other essential businesses have done, is there's a time for high-risk people to come to the store, pushing out home delivery and drive-through, things like that. So there may be downstream effects. Like I said, false positive, false negatives. Maybe one test, the 2-minute test, actually is better than the 5-minute test, but we're going to find out that stuff. So it's just about paying attention to that. I'm going to talk about treatments. Jeff DeRicci said, thanks, Jeff. Can you please discuss reinfection? Everyone's been quarantined after their positive test, but once in recovery, are they opening themselves up again, or do they have some type of immunity? Most of the experts, including the expert, let's just call him the chief COVID scientist, which is Anthony Fauci, who's been through every epidemic that we've had, Zika and Ebola and prominently HIV in the last 30 or 40 years, has said that it's very likely that people have immunity. And this goes back to the importance of serologic testing to say, okay, my partner is a teacher. If she's going to go back and teach in the fall or possibly this spring at her high school, should she get tested before she goes? Will we have enough tests to have teachers go back? Do I want my kids are in elementary school? Do I want their teachers tested or their colleagues tested? We don't have all those answers. We don't know the availability. We know the tests are being developed. They're being deployed. And as one article said, this effort to fight COVID-19 is literally the greatest effort, scientific effort, and most rapid effort of all time, essentially. And so we can say the countries aren't sharing data and we don't know those things. They really aren't productive. It's really important to focus on the positive that there are 40 companies working on vaccines. And so I'm very positive about a vaccine coming out of this. Human trials are happening right now. And a vaccine plus effective drugs that are proven in randomized clinical trials, serologic testing, and most importantly, rapid point of care testing and keeping people away from each other. We're going to have a degree of people recovered, but that number of people recovered is going to be only highest when we stay home for the next 4 to I don't know how many weeks, and not go out and tell other people to do it while maintaining as best we can our mental health and connection with people, as long as it's not physical connection. So I hope that answers your question, Jeff. Jeff's also famous for being one of the pharmacists who's on the provider calls that we've had. So always love it when pharmacy makes our voice heard. So let's talk about treatments. One of the questions that Dr. Melbourne asked here is discuss potential treatments. This was also reviewed in the provider call today. And so I'll give sort of my spin on it. Remdesivir is made by is a drug that was originally used for Ebola. Probably the most promising treatment. I'll echo Dr. Phil Chan, who is leading the effort at RIPA as an infectious disease specialist. So remdesivir, newly expanded clinical trials are going on in Rhode Island and many, many other places. And I applaud the company and those who are studying that for severe cases. So let's be very clear about, do I want a treatment to prevent me and my family from getting COVID-19? Yes. There are some drugs being tested right now at the University of Minnesota. One of them that we probably are all familiar with, hydroxychloroquine, with or without azithromycin, to try to prevent disease, again, for the highest risk people. So we're thinking long-term care facilities and healthcare worker families. So we're going to see more data on that. Remdesivir is an intravenous drug used for a few days for critically ill people. And so we'll know more data coming out. Let's talk more about hydroxychloroquine, also reserved for inpatients. We have FDA guidance that's now emergency use authorized. We also have emergency regulations that went into place. Every day seems like a year here. I think that was only Sunday. Maybe it was a week ago Sunday. I can't remember. Use your judgment that anyone requesting hydroxychloroquine in the community is not using it right unless they're treating lupus or rheumatoid arthritis or other conditions. And it's unfortunate that there has been hoarding and there has been shortages. So now people who were using it can't get it, and hospitals that need it to test and treat patients in the hospital aren't getting it. And it really, again, needs to be in clinical trials, with those outcomes being keeping people off a ventilator, keeping people out of the ICU, things like that. Megan, great question. Should retail pharmacies continue to provide vaccinations during this time? I think use your judgment. Again, we still have a month of flu season left, even though the numbers are, greatly decreased as they typically do this time of year. If somebody wants a flu vaccine, I would love that you'd have PPE to be near this person. You have to be healthy to get a vaccine. And so if they fill out a screener, and they say they're healthy that day, and you feel comfortable giving them a vaccine, sure. I think I would be selective to influenza and pneumococcal because of their protective effects to keep people essentially, in some studies at least, out of the hospital. Okay, so treatment. So I talked about remdesivir. There are some there's an antiretroviral drug called lopinavir ritonavir. Probably doesn't work. Some people think maybe it works in combination with other drugs. Not sure. Azithromycin should not be used alone. So again, even though we don't have guidance and we probably don't have a shortage of azithromycin, and we've all dispensed, including me, 90% of azithromycin, hand it to the person and go, hey, this is going to treat your viral infection. It only treats antibiotics. It probably is true for this virus. There are studies going on with azithromycin and hydroxychloroquine or Plaquenil. But again, we just don't know. There's no role in the community for either of those drugs or together. Thanks, Chris, for posting that fact sheet on hydroxychloroquine. So that's what's going on with that. Other drugs. The American Society of Health System Pharmacy, they've just expanded for free access to their site. They have a great chart. idstewardship.org, I think, is a great site, and they review all those drugs. My colleague, an expert, ID expert, Carrie LaPlante at URI, has organized and led a website on the Society of Infectious Disease Pharmacists. That's easily sidp.org. They have some great videos on efficacy of these drugs. So I think that if you want to know more there, but I think from a practical and community saving effort is azithromycin only for bacterial infections, hydroxychloroquine only for people with a diagnosis of lupus or rheumatoid arthritis or other, or I guess malaria if somebody's going to a malaria area, which they should be doing anyway, but if they have to go, maybe they need that, or chloroquine in that same way. Only for those things, because in the community, it's just not, we don't have any data on either prophylaxis or treatment. Remdesivir, again, in the hospital, anti-Ebola drug candidate, and now probably the most promising drug for that. And there'll be many more coming out. Maybe we'll do another one of these things to do that. Okay. Great. Love all the facts. Thanks, team. I thought what we're doing is helping make cases keep going up. Every day seems worse. The daily announcements are making my friends anxious. Can you hold less frequent briefings? So one of the reasons that we, Rhode Island and Rhode Island Department of Health and all the other state agencies and the governor's office, that we do briefings every day. This is how you manage emergencies, especially in the early part of an epidemic. It's, turn off those alerts. I didn't do that. And I just, I have anxiety. I don't know anything about psych, but I've got anxiety about this stuff. So I try to say, I'm going to stop watching at this point. I'm going to stop listening to these things. We know the trajectory. You can log on to any major news site, see those graphs, go to the Johns Hopkins site and see where the cases are going to go, see when the peak's going to happen. We think in Rhode Island, according to modeling, you hear about 200,000 dead if we do everything right. It's horrifying. It's unimaginable. It's going to touch all of us. But all we can do is focus on what we can do right now and what we can do when this is over, and know that pharmacy is going to be stronger, and know that everyone who goes out there on the front lines, people we know, people, our partners, our work, it's really, really, really important. And the national associations have your back. The state associations have your back. We want to hear from you. We want to answer your questions. So keep sending those questions. Okay, so that's how to reduce anxiety. Let's see, what do I do with my kids who are home from school here in Massachusetts? We make movie trailers, so that's an exciting thing. And we have baby chickens. So that's my excitement as I wake up and work and listen to the chirping in my yard. So I'm not saying you should get baby chicks. I'm just saying that's something that we do. So you do you. I did a spin class, and so I'll post that too online, because I do lots of things. Back to questions. Do you think using more azithromycin will increase antibiotic resistance? Yes, it's overused. Don't use it for COVID. Done. There's minimal data. So I think we talked about hydroxyzithro, types of patients. Again, we think severe patients, it's really best in clinical trials. We don't know. There's other drugs being used that are sort of oncology drugs, IL-7, IL-6 receptor antagonists, things that I know very little about that may be effective. So that's what's going on there. Thanks, Dr. Schwab, super duper star of my life here on guidelines for mental health that you can do. Very, very important to not only monitor yourself in terms of mental health. We are attempting to do our best to maintain my remote class that we're teaching on another epidemic that is currently happening in Rhode Island, the opioid use disorder epidemic. And so we check in, and we encourage students to check in, and we are flexible with dates and flexible with assignments, and we just got to be flexible in every way. So we talked about treatment. We talked about mechanism of action. I think Emily did a great job summarizing that. Do NSAIDs really worsen COVID-19 symptoms? We don't know. There's no data. That's what that is. Really interesting question about if 50% of cases are asymptomatic. So again, the most recent data-ish is that maybe 25% that you're transmissible. 1 in 4 people are transmitting while asymptomatic or have mild symptoms. Is the true mortality rate lower than 1%? There was a publication today, I think, out of China that the mortality rate was 1.38%, which is at least 10 to 15 times that of seasonal influenza in a bad year. It's high. We need efforts to reduce mortality, and reducing mortality is by reducing exposure to people. The scariest thing is mortality that will happen because we aren't able to provide care to other people. For example, people may be upset that liquor stores are closed in some states like Pennsylvania. So I have colleagues who work in who treat patients with alcohol use disorder. If you don't have access to alcohol, people who use alcohol will go into withdrawal, which is deadly and requires ICU care. So there's actually a method to what is essential. And you may scratch your head and go liquor stores, but there's a whole lot of people with alcohol use disorder and a whole lot of people who are treating the anxiety with alcohol. And so we, again, just monitor yourself and your colleagues about what's going on with that. Can you comment on, so again, is the true mortality rate lower than 1%? It may be. That would be positive, but we have in New York City overflowing ICUs. We need thousands more ventilators than we have accessible. We're going to really extreme measures. If you look at Italy, they had to ration care, and we want to avoid rationing care in as many places as possible, including Rhode Island, but really everywhere. And that's one thing we need to do. Great. The summary was just posted. Thank you, Matt LaCroix. So can you comment on continuously evolving and conflicting information from CDC and World Health Organization or WHO? Mode of transmission and contact is distance. Yeah. So there's some data that says that this virus can be transmitted in aerosols, that you can culture virus or identify virus on surfaces, sometimes up to a day. So I'm going to sort of answer that two ways. As much distance as possible, as little time as possible, reduces your risk and exposure. That's all I can say. So if you want to believe if you think it's 3 feet, 6 feet's great. If it's 6 feet, make it 8 feet. You want to limit that exposure as possible. How long will this last? That is a great question. So I took a bunch of sites and great. Thank you, Dr. Sanson, for the ASHP treatment summary. So how are we going to get out of this? It's really going to be testing. It's really what we've lacked. There's still time to do it. Experts are saying that. Scientific experts, world leaders, public health leaders all say testing is the issue. This is what worked in other places. Some experts have said we need to see how many ICU beds or what percent of ICU beds are occupied, and let that be the determination of when we perhaps relax social distancing. Right now, all we have is social distancing, and that is it. We don't have a vaccine. We don't have effective countermeasures. We have washing our hands for 20 seconds. We have using hand sanitizer. We have covering our coughs. Maybe we have masks. The data is really scant. I just got an email before I went on here that said the data that says everyone should wear a mask is really lacking. The data that homemade masks work is really lacking. It has some effect. But does that have a more negative effect on your family or when you're out in public? I don't know. Yeah, so Karen had a great question here. What's your opinion on DIY? It's sort of like it's better than nothing. And so it's hard for me to say, don't put on a bandana. Maybe we'll get you PPE, but that's really sort of where we're at. So we need to confirm that countermeasures work. We do need vaccination, and we do need that serology. And I think that's sort of my 5 points that I made in the document that we had here. Great. So let's go to other questions. What does the data say about hydroxyzithril? I heard this may affect the heart. Yes, some of the folks who have conditions that are now relatively proven to be associated with more severe disease, ICU care, and death and mortality, have conditions that may be worsened by hydroxychloroquine or azithromycin. So we don't even know if it's those severe folks, if it helps younger folks. We don't know that. That's why we do clinical trials. That's why we get evidence. So we talked a little about Italy and other countries. We're really looking at any country for success on that. What are some strategies to calm yourself? So again, that NAMI site I think is great. There are, and have always been, in case you don't know, ways to text mental health professionals. On some of the provider calls this month or last month, you now can do telemedicine with mental health professionals. I'm sure they're getting really good at it really fast. It can be only on the phone. Your insurance has to pay for it. Your providers are getting reimbursed for that. One thing I'm looking into, and I'll take any advice, is can pharmacists do telemedicine and get paid for it? Seems like it's time. This is the time to identify those barriers that didn't need to exist in pre-COVID times and make sure they're gone so we can provide the best care for our patients. How do you feel about seniors who are still running around to get groceries while the young and health are quarantined and getting food deliveries is completely like a support for the high risk? It takes a while for people to realize just how unprecedented this is. So it doesn't improve my mental health to get mad when I see spring breakers partying together and then develop COVID-19 and know that they probably exposed someone who is at high risk unnecessarily. It doesn't, we can't be mad at that. We do, speaking of spring break in Florida, the governor today just put a shelter in place order in. We can say, wow, that's too late. We knew this a month ago. At least it happened. I think we need a national shelter at home. I agree with experts. It's not just me. So we need that. If you're out and about getting essential things, grocery stores are open. I think that at least in my area, grocery stores are doing a good job of trying to protect folks. Again, that time that's only for high risk folks, keeping people distant at the stores. So, I don't think there's a complete lack of support for the high risk. Younger people are on Facebook Live, perhaps, and are more connected to different kinds of communication techniques. And so maybe the word just literally isn't out, but it's sort of everywhere at this point. You can be that person to, I called my dad, my 79-year-old dad in Minnesota, and I said, Dad, you can't go to coffee with a bunch of other high-risk old guys. And he's like, but I got to go to coffee. So I think those Gen Xers and Gen Ys like me are sort of going, boomer. But, the personal message maybe is better than TV, or maybe TV is better than that. So I'm not sure. Is there progress towards some measure of immunity? So I talked about that a little earlier about serology testing. They're just coming into place. You think they're coming to Rhode Island. From, who is this? Daniel Lefkowitz. Okay, yes, former president of RIPA. Is RI setting up alternative hospital settings? Yes. A lot of folks have asked me long ago, actually, about Memorial Hospital. They said today that that's off the table. It's not accessible to do it. But there are other, I believe in the briefing, they said 15 to 20 sites are being looked at for alternate settings, much like the Comfort, USS Comfort hospital ship, 1,000-bed hospital ship going to New York Harbor. That is going to be for non-COVID patients. For obvious reasons, ships are not a place to have COVID and limit spread. How many different strains of viruses are circulating? I haven't heard much about that other than it's probably not getting worse and not getting better. Viruses mutate. They have messy proteins that translate their RNA to DNA and replicate their proteins. Just coronavirus is no different. So sometimes the virus can mutate to be worse. Sometimes it can be better. We don't really know a lot about coronavirus other than SARS-CoV-1 from 2003, which also was first found in China and spread not ever to the US. I was practicing then, and it was a pretty scary situation, but didn't happen. Are states performing contact tracing? Can pharmacists play a role here? I have made strong recommendations that I think pharmacists could volunteer to do contact tracing. It's being done in other countries. I think I sent my student a link. I sent her lots of links. She's very accessible about pharmacists doing contact tracing. It's just one of the things I think we can volunteer for. And again, riresponse.org is posted. That's where you can volunteer. And as we do contact tracing, we'll do that. But as community spread goes essentially everywhere, essentially the health department has said, if you have symptoms, you have to assume it's COVID-19, period. So yes, we're performing contact tracing. I think the latest data on the website, on our RIDO's COVID-19 website, is there's 1,000 people under quarantine, but we don't really know. Yeah, great. That's actually, I didn't talk about that with treatments. Krisha, thanks for your question. Can you speak to using antibodies from blood of recovered COVID-19 patients as a treatment method? FDA gave provisional recommendation to what's called convalescent sera. This is over a 130, 125-year-old technique where, again, going back to determining who has immunity, even some of those first cruise ship passengers went to this biodefense lab in Nebraska, and they were getting sera there. So if you can get it, as we have more recovered people, we can donate our blood, donate our sera, and use convalescent sera. And I think there's a case report of success. I can't remember if it was the U.S. or another country, but that's absolutely something that we're doing. Dr. Correa, are you hearing about med shortages? Yes. And I've talked to the people about med shortages. I'm sure we've always had med shortages, and now we particular medications that are shortage. This is in Stat News, and I think in NBC and other major networks today. The medications used to keep people comfortable and sedated while ventilated are actually in short supply. They were in short supply before. If anyone works in a hospital, I used to work in an ICU and know those meds well, and taught students in that setting. So opioids, fentanyl in particular, and paralytics. So people who get severe COVID-19 disease go into a disease called acute respiratory distress syndrome. And so there's extra drugs like paralytics that you need to use to keep people comfortable and safe and improve their condition. And they are in short supply. But again, reassure you that the Rhode Island Department of Health is aware of that. The hospitals are all talking. All the critical care experts are talking. We have an international expert in the state. Dr. Levy is an international expert in that. Should we be recommending meds without confirmed efficacy? No, we shouldn't. Should not be recommending any meds unless you're a hospital pharmacist and you're enrolling people in a clinical trial. I think that's what we need to do. And again, I heard today that there's actually great success in those remdesivir and hydroxychloroquine trials and some other drugs that will soon be trialed and enrolling patients in Rhode Island. So as dismaying as it is that we'll have so many critically ill people in Rhode Island and elsewhere, at least know that that people have this opportunity to be given an experimental drug that might have help, that will help other people as we gather that data. Great, the QT prolongation from FDA. Thanks, Chris. Once patients are infected, can they get reinfected? So we talked about that. As far as we know, no. We're not really challenging people with it. Is it in general better to have antibodies or to have them through the vaccine? Since we don't know anything about vaccine efficacy right now, they've just started safety trials in humans, I think literally today. But there's 40 companies studying different kinds of vaccines, and so I know that there'll be a vaccine. Remember, the day that the front page of whatever website or newspaper you read says vaccine effective for COVID-19, the fine print is going to be important in who it's good for, what the effects are. Does it prevent disease, treat disease, do both? How long does the vaccine last for? Does it generate an antibody response similar to exposure to the disease? Does it protect high-risk people? Has it been studied in that? All those things are going to happen. And then the clock starts again towards manufacturing enough vaccine for everyone who's unprotected. And so that will be billions of people that will need to create vaccine and do that. I'm trying to stay positive. I focus on the positive. It's great for your mental health. There are 2 companies that have already been contracted with the federal government to ramp up vaccine manufacturing. So that's good. Can you speak on the shortage of MDI inhalers in the setting of avoiding aerosolized medications? Right. So I've heard that in 2 settings that I've heard, and these are anecdotes. This is not data, but in Rhode Island that people couldn't get MDI, so they're getting nebulizers in the community, which create aerosols and greatly increase the potential spread of COVID-19. And in hospitals, they were told to not generate aerosols because that means you need N95 masks. So they're using inhalers or inhalers with spacers, learning to reuse spacers, but that now that hospitals can't get MDIs. For COVID, the setting of avoiding aerosols for COVID positive and potential realize how will this be changing? We're trying to do our best to try to increase access to MDIs, and that's all I know at that point. Dr. Sanson says, what are some things pharmacists can do to educate the public and help keep patient out of the hospital? Well, that's great. So again, if you don't have shortness of breath, if you have other symptoms, and unless you're essentially me and my family, I've been self-quarantined and not exposed to, as far as I know, anyone with COVID-19 in 3 weeks. So I'm pretty confident that if I develop symptoms, it's not COVID-19. Although I did get my spin bike today from the gym. Thank you, YMCA, to teach class virtually to keep my mental health up. So please keep exercising and tune into my videos. I'll post them on my Facebook page. So how can people stay sick? Again, think of your patients with diabetes or patients with kidney disease and make sure that they're staying in contact with their physicians about whether to continue medication, stop medications. Staying hydrated, is always an important effort, especially when people have fevers. Make sure people keep eating. And again, this is not just for you or your patients, but also your friends and family to sort of maintain those same sick day management techniques. I think I have a few more things to say about that when I get to my question here. So I think I've answered some of these other questions. We have about 3 minutes left here, and we'll try to get more questions, keep posting to our FAQ page. Thank you again to the leadership of RIPA, all the participants here. This is archived. I'm going to say it again. If you've made it this far and it's April 3rd, some of this may be out of date. Go to the RIDO page, the RIPA page, go to the CDC, WHO. Since you're watching this in social media, don't spread myths, spread positive, accurate information, and CDC has a lot of them. This virus is said to be worse than older underlying health conditions. There have been deaths among younger adults. Again, yes, a significant percentage of people who've gotten positive COVID-19 tests are under 65 or under 55. Some of those people have severe disease, most of them with chronic medical conditions. Some of those people, have died. And when you look at the thousands of cases of any disease, some percentage of them will be healthy and young. And so it's important that we all avoid transmission as much as possible. I'm not saying that it's higher risk for them. We know that it's significantly lower risk of severe disease, of hospitalization, of ICU care. But my former colleague in a hospital in New York posted on Facebook that his colleague, a physician, died. There's the ER doc who died. There's the original doctor in China who died, who was young and presumably healthy. Do we know why they died? We don't know. We don't know a lot about this virus. We know a lot about how transmissible it is. We know how to reduce transmission. We're researching vaccines. We're researching countermeasures. Nothing is effective right now. And so I think that's important. Let's see. One last question here. We talked about the symptoms too. Do retail pharmacies need to keep a contact tracing log for every patient or family member we interact with, as requested by the governor yesterday? In and out of the windows along with OTC aisles. That is a great question that I'm going to pass up through the people I know. I think that considering that pharmacies are operating at 100 to 200% of their normal operating, I think that isn't an issue. Oh yes, the future Dr. DeAngelis. Of course, how could I go through this? The impact of COVID-19 and the opioid crisis is severe. Marginalized people now have no job. Homeless people are even more marginalized. It's very, 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 very important to continue doing harm reduction, selling syringes, selling boxes of syringes. I've got an effort to try to encourage secondary distribution, because the last thing we want is an HIV or hepatitis C outbreak there. We want to think about people getting their opioids. Yesterday, the SAMHSA and DEA said that buprenorphine or Suboxone prescriptions can be prescribed for the first time or continued via telemedicine, audio only, along with other controlled substances. And we have to think about what happens when people are cut off from their opioids, cut off from their illicit opioids. So, man, get naloxone out for everyone. Don't ask questions. Recommend it. Get it out there. There's many more people who are going to be using alone, right? We're recommended to be alone. People are still going to be using. People are going to be coping more with alcohol, with opioids that they can get a hold of. People in chronic pain we have to think of in continuing their opioids and encouraging them to maintain that, because going to withdrawal is going to be even more severe it's going to be severe for them. People stopping benzos, people starting benzodiazepines. Not a fan, but I think that if that is something a prescriber says that a patient needs and they do a telehealth and they call it in or they e-prescribe it, she should be e-prescribing it. That's fine. There'll be notices, again, through RIPA and through other Board of Pharmacy emails on sort of hopeful regulatory changes that will help you do your job better, reduce the burden, reduce the number of people in the pharmacy, those high-risk people, and helping out there. So I'm going to sign off. Really appreciate everyone who listened. Share this around. Go to those legitimate websites. Stay calm, and keep doing what you're doing. And that's all I got to say about that. Thanks.